So we can divide causes of jaundice into prehepatic, hepatic, and posthepatic causes. And we're gonna focus on the prehepatic causes now. So that's this part, okay? That's all the way up to conjugation of the bilirubin by UGT. So the first cause of prehepatic jaundice is something called physiological jaundice of the newborn. What happens is when they're born, they have immature UGT activity, as you can see here. It just doesn't work very well. And it takes some time to increase its activity. So these kids, they're not conjugating the bilirubin well, so you're just building up this unconjugated bilirubin in the blood. So if extra bilirubin in the blood deposits in the skin, causes jaundice. What else it can cause is something called kernicterus, and this is unconjugated bilirubin depositing in the brain because it's lipid soluble. That's why it's not water soluble. It's lipid soluble, and the brain is a bunch of lipid. So if you get this deposition in the brain, you're going to cause a bunch of neurological symptoms. So that's a bad thing. So first of all, normally this occurs after the first 24 hours of life and usually self-resolves in 1 to 2 weeks. Okay, so there's newborn babies getting jaundice. This is physiologic jaundice in newborns. And what we do to treat them is we can give them phototherapy. Basically shine this light that helps make the unconjugated bilirubin water soluble. You're like bathing the baby in this light. And that's to prevent this kernicterus and the neurological problems of physiological jaundice. The next cause of prehepatic jaundice is hemolysis of red blood cells. So we said that bilirubin comes from breakdown of heme in the red blood cells. So if you hemolyze, if you break down red blood cells too much, you're going to get too much heme and thus too much bilirubin. So high levels of unconjugated bilirubin. And a lot of the symptoms will arise from your hemolysis of red blood cells. So you're going to get anemia. You're going to get pallor, you're going to get fatigue, you're going to get shortness of breath. All due to the reduced levels of red blood cells and hemoglobin, so there's less oxygen carried to the tissues. Next is Joubert syndrome. We're going to be focusing here now. Joubert syndrome is something with mildly decreased UGT activity, so it's just lightly decreased. A lot of it works, so there's enough activity that you're pretty much asymptomatic normally. What happens though is that you will develop mild jaundice during times of stress or fasting, where there's increased, basically you overwhelm your ability of this UGT, and you get a little bit of unconjugated hyperbilirubinemia, causing mild jaundice. So it's a patient that you see that's normally very healthy, he's normally never had a problem, but then he suddenly gets jaundice for no reason, except for that he had some recent stress. You want to suspect Joubert syndrome. Now, the other inherited disease, Joubert syndrome, first of all, is inherited because it's mildly decreased. It's a inherited decreased UGT activity. The other one is Crigler-Najjar syndrome. This is a more severe inherited problem with UGT because it's completely missing. There is just no UGT activity at all. So you can tell this is much more severe. You're going to get jaundice, you're going to get kernicterus, because when they're newborn, they just have no UGT activity. And this is usually fatal. The one way you can treat this is with the liver transplant. So if you give them a new liver, that liver will have UGT activity. So again, physiological jaundice has decreased UGT activity, but that's just transient. Okay, in the newborn, it's going to get better over time. Hemolysis is just increased production of that unconjugated bilirubin. Joubert syndrome is inherited decreased UGT activity, so it's going to stay forever. It's going to be forever mildly decreased, but it's usually asymptomatic. Crigler-Najjar is very serious because you're completely missing UGT. So you're going to get super high levels of unconjugated hyperbilirubin in your blood. Okay, next is the hepatic causes of hyperbilirubinemia, and this will be conjugated hyperbilirubinemia because we're talking about stuff that happens after conjugation. This is problems of the conjugated bilirubin leaving the liver. So the very first one is another inherited disease. It's called Dubin-Johnson syndrome. This one has a defect in hepatocyte bilirubin transport. So you get that conjugated bilirubin inside the liver, but you can't kick it out. You have problems moving the liver out into the bile ducts. The only thing that this is significant for is a black liver, but it's very testable. Okay, so if you see a black liver, a dark liver is what I like to think of it as. You think Dubin-Johnson syndrome. Otherwise, completely asymptomatic. The twin sibling of Dooman-Johnson syndrome that is not dark is Rotor syndrome. I say it's not dark. Again, same problem. Defect of hepatocyte bilirubin transport. The thing is that the liver is a normal color. It's totally asymptomatic. There's nothing wrong with this patient at all. Okay, they have no discolored liver, totally no symptoms, nothing. Rotor syndrome. Alright, next cause of hepatic hyperbilirubinemia is viral hepatitis. I want to note that this one actually has mixed hyperbilirubinemia. Mixed as in it has both unconjugated and conjugated increased levels of bilirubin. Why does this happen? Because the viral hepatitis inflammation causes damage to both hepatocytes and small bile ducts in the liver. So you have these bile ducts in the liver, these all get damaged due to that inflammation. So hepatocyte damage means that you have problems here. And then if you damage the bile ducts, then you can't leave. So first of all, you're not conjugating bilirubin well, so you increase unconjugated bilirubin. And then over here, you're not excreting whatever you do conjugate, so you have increased conjugated bilirubin. So you have both increased. Your symptoms here are going to be hepatitis syndromes, which we'll talk about in another lecture, but it's basically things like jaundice, abdominal pain. You're going to have infectious symptoms like fever, because this is virally mediated. And you're going to have something called obstructive jaundice. Like I said, we have blockage of the bile ducts here. So your bile is not going to flow out. Remember, bilirubin is part of the bile. It's going to be incorporated with bile acids. It's going to be bilirubin, bile pigment, which include bile acids, bile pigment, cholesterol. Cannot flow out the bile duct, so what's going to happen? It's going to go into the blood. Okay. So first thing you're going to have is you're going to have decreased bilirubin in the gut. So now you're going to have less stercobilin. So your stool is going to be pale. And then now you have increased bilirubin in the blood, and it's going to go into the urine. So then you're going to have dark urine. And you're going to have increased bile acid in the blood, and that's going to cause itchiness. It's going to deposit in your skin, and you're going to be itchy. So that is obstructive jaundice. Keep this in mind. Pale stool, dark urine, bile acids. That's obstructive jaundice. You see it over and over again, even in this lecture. So next is biliary tract diseases. So these are problems. It's calling destruction of bile ducts inside and outside of the liver, and this prevents outflow of bilirubin in the bile. So again, this is an obstructive jaundice. So the two ones you'll see is primary sclerosing cholangitis and primary biliary cholangitis. We're going to have lectures on those later. Again, I just told you it's obstructive jaundice, so what are the symptoms there? Remember, it's pale stool, dark urine, and you get itchiness, also called pruritus. The other thing you see is hepatosplenomegaly, because you have impaired outflow. Hepatosplenomegaly means enlargement of the liver and of the spleen. You have impaired outflow, you have congestion, and it basically enlarges. Now we have post-hepatic causes. Again, you get conjugated hyperbilirubinemia. Again, it's impaired excretion, but it's due to the bile ducts outside of the liver, okay? The problem is the bile ducts outside of the liver. And it can be obstructed by gallstones, pancreas, or so gallstones here, gallstones blocking excretion of bilirubin. You can have pancreatic or gallbladder cancer, pancreatic cancer. All of these block the bile ducts. So your bilirubin cannot get into the gut, into the small intestine right here. Okay. What is going to happen? What symptom? What is that classic syndrome I was just telling you about? You're going to see obstructive jaundice. Okay. What are the symptoms again? Do you remember? Pale stool, dark urine, pruritus. You're also going to see some fat and fat-soluble vitamin malabsorption, because your bile is not going to get into the small intestine because it's completely blocked up. And so you're going to get greasy stools because lipids aren't getting digested. You're going to get poor fat-soluble vitamin absorption, so vitamin A, D, E, K. Okay, so that's all our causes of jaundice. Very interrelated to this, there's the pre-hepatic causes, there's the hepatic causes and post-hepatic causes. Make sure to know which type of if it's unconjugated or conjugated hyperbilirubinemia, because that's gonna help you narrow down your differential a lot more. Okay. And then just know the obstructive jaundice presentation. That's it for jaundice.